Any dietary supplement sold moving forward on Amazon will have to be analyzed by 3 laboratories that they actually selected, one of which is Eurofins. So they will send it to Eurofins, they'll get the results, and if the results are not within 50% of what you claim on the label, you're out.
Welcome back, every Bendy Body, to the Bendy Bodies podcast with your host and founder, Dr. Linda Bluestein, the Hypermobility MD. Today, we're going to be digging into so many more things about mast cell and mast cell activation, and hopefully this episode will help so many more people get accurately diagnosed and treated. But first, let me share with you a very special treat. My friend and pain medicine colleague, Dr. Pradeep Chopra, is back as a guest co-host. Most of you know Dr. Chopra for his incredible work in EDS, POTS, MCAS, CRPS, and central sensitization disorders. For the 2 or so people on the planet who don't know Dr. Chopra, he is a Harvard-trained, board-certified pain medicine specialist with over 25 years of experience treating complex pain and multisystem disorders. Jennifer Milner and I interviewed Dr. Chopra for episodes number 70 through 73, which covered the impacts of EDS in a head-to-toe fashion. Dr. Chopra also joined me as a guest co-host for episode 77, where we interviewed world-renowned EDS specialist neurosurgeon Dr. Paolo Bolognese. So I'm so excited to have Dr. Chopra back today. How are you?
Good. Happy to be with you again.
And our guest today is Dr. Theoharis Theoharides. For part 1 of that conversation and to hear the more detailed bio, please check out my first interview with him on episode 139. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Let's get started. All right. Well, I am so excited to have Dr. Theoharides back today because we had a great conversation in part 1, which was episode 139. And as you know, I have Dr. Chopra here as my guest co-host, and we're going to have a great conversation. I'm so excited to chat with both of you.
Same here.
Thank you.
I think that today it would be really helpful if we can really present information about mast cell activation syndrome that would be really applicable to primary care providers. And so that patients, when they go to primary care providers, they can say, I heard from this expert, Dr. Theoharides, like this is what he says we need to do in terms of the symptoms we should be looking for, the tests that we should be looking for. These are some of the treatments that can be useful. So I think if we can maybe have this conversation through that lens, I think that is a way to help a really large number of people. Does that sound okay?
Yes.
It's a loaded topic, but yes.
Yes, yes. Yeah, we could, of course, talk about this for hours, hours and hours and days. And I know that we wouldn't even scratch the surface of what you know. So, but I think it would help so many people because we know that not everyone can access the 3 of us. A lot of people have to work with the doctors that they have local to them. And so I think we can help a lot of people by really thinking, what should a primary care provider be thinking of when they see a patient with certain symptoms? When should they start thinking about, could this be mast cell activation syndrome?
Well, this is very opportune because my good friend and colleague that you all know, Anne Maitland, and I just submitted a huge review, about 600 references, an invited review, and the title is Mast Cell Activation Disorders, comorbidities and lookalikes. So that will explain a lot of the things in much more detail that you're asking. So I don't like the word or the title mast cell activation syndrome simply because it is very, very restrictive and it doesn't really help our patients. So I like the term mast cell activation disorders because there are 3 diagnostic codes. There is other mast cell activation disorders, there is mast cell activation unspecified, and there is mast cell activation syndrome. So starting backwards, if you wish, all of those need medical history of telltale signs of activation of mast cells. And those could vary, of course. It could be itchy eyes, it could be runny nose, it could be flushing of your neck and torso, it could be itching of the skin, it could be diarrhea, and then further down the line, headaches, sometimes difficulty breathing, bloating, etc. That's number one. Number two is that at least use of some quote-unquote drugs that help in such conditions, such as the so-called antihistamines or the anti-leukotrienes, might have helped you in the past, should anybody have, of course, suggested those. And now comes the tricky part. What are the objective findings? For mast cell activation syndrome, there's got to be elevation of this unique mast cell enzyme called tryptase within 48 hours of an episode. But that makes it extremely restrictive because, number one, you've got to have an indwelling catheter to draw blood within 48 hours. If you go to an emergency room, no one knows what you're talking about. And most places don't even measure tryptase. That's problem number one. Problem number two, even if tryptase is elevated, which in most cases of even mast cell activation syndrome, tryptase is not elevated, we have no way to address that anyhow. So when we talk about treatment, the treatment approach is the same, whether it's mast cell activation unspecified or syndrome. Now, Dr. Butterfield from Mayo Clinic published a number of papers where he measured some metabolites or breakdown products of mediators from mast cells, such as leukotriene C4 and such as prostaglandin F2 alpha, and elevated levels of those, along with N-methylhistamine, were more predictive of bona fide mast cell activation syndrome than tryptase elevations. So he looked at a whole bunch of patients, and only 1/3 of the patients that he was an expert identified mast cell activation syndrome had elevation of tryptase, but 2/3 had elevation of the other breakdown products in the urine. And finally, a paper was published about a year ago, and my friend and colleague Mariana Castells wrote an editorial about it, where some other colleagues measured serum tryptase levels without necessarily any diagnosis, just to see if they were elevated and then try to relate it to a diagnosis. And in that study, the cutoff was 11.5 nanograms per milliliter. And as it turns out, 1/3 of those had what we call hereditary alpha tryptisemia, which is non-mast cell activation. The other third, surprisingly, had chronic kidney disease, and the remaining was aggressive mastocytosis. Not a single patient with randomly measured tryptase had mast cell activation syndrome. And because of that, our colleagues who usually write about criteria raised the bar, and now the cutoff point for tryptase is 15 nanograms per milliliter, up from 11.5. So, all in all, to the patients out there, if you have these symptoms of being sensitive to God knows what, then you do see whomever physician you can see and just say, I have mast cell activation, and here why. Don't necessarily say syndrome, because then they will say, well, tryptase is not elevated, you have nothing, go home. Okay. So let's start with that.
So when I first learned about mast cell activation, I thought, wow, they're like putting everything in this bucket because, the GI symptoms, of course, are quite common. Headache is quite common. A lot of these things, the flushing, of course, is more specific. But how do we know this constellation of symptoms when it's due to something else and when it's more likely to be mast cell activation?
Dr. Chopra, your input.
So my thing is that in the diagnosis of MCAD, from now on I'm going to call it disorder, mast cell activation disorder. There are three parts to it. For the primary care physician who's listening to this podcast, who's trying to learn about MCAD, what would be a typical presentation of a patient coming in with MCAD? It looks a lot like body-wide pain, skin flushing, itching. Anything else you'd like to add?
Do you want to discuss a difficult case or a rather simple case? I mean, the simple case would be someone itches like crazy. They're going to the shower. Hot water makes them itch when they get out of the shower. Uh, they uh, they smell some perfumes and they flush. In other words, these are symptoms that are not typical allergies. In other words, if someone is not, and we'll talk about the diagnostic, objective diagnostic parts, but in a typical allergy, so to speak, you might be allergic to, let's say, pollen, and you get all stuffed up, and you get rhinitis. You might have chronic rhinosinusitis. Um, you might itch if you touch certain things. So these are kind of more typical allergies. In the mast cell activation disorder patients, they respond to things that are not allergic. They're not necessarily IgE mediated.
Correct.
Which the risk of someone having allergic reactions, it's almost the same, roughly, within the overall population and within the MCAD group. It is that they respond to everything else. So today, for instance, I had a patient, without even saying what she may or might not have, I did what we usually do. I just scratched her underarm. Within 1 minute, he had a red line. So that means that the mast cells in her skin reacted just to the pressure and nothing else. So I know this patient is likely to have MCAD because the mast cells responded not necessarily to an allergen that would qualify them under the category of number 2, mast cell activation disorders. And maybe we should just mention that first, because in the categories of mast cell activation disorders, we have the primary, which is systemic mastocytosis or cutaneous mastocytosis, and a few extremes. Then you have the secondary category, which is kind of the bread and butter of the allergies. So it'll be rhinitis, conjunctivitis, eczema. And then you've got what we don't understand in medicine, the idiopathic. And under that, you have idiopathic anaphylaxis, you've got idiopathic, edema, and then you have mast cell activation disorders and mast cell activation syndrome. So that's kind of where it is.
So to the primary care physician, patients will present with, and I have a list of symptoms that I look for: skin flushing, unexplained itching, multiple chemical sensitivities, headaches, sweating, especially at night, flushing after a hot shower, so hot to cold temperature change, brain fog, uh, belly, abdominal discomfort, usually is bloating, diarrhea, fatigue, and symptoms that get worse during their menstrual periods. Not pelvic symptoms. I'm talking about generalized symptoms. And of course, dermatographism, which. But here's the one that's also baffling: is weight gain, or weight loss, or weight fluctuation. Is that correct to add in the list?
Well, then I wouldn't necessarily, in all honesty, going back to the symptoms you mentioned. And that's why in this recent chapter that we submitted, we take extremes, going after those. Clearly you've got to, and when I say you, I mean anybody, of course. I don't mean, you. We have to make sure that we exclude other possibilities, even though some of the possibilities may or might not involve mast cells. So, for instance,
Right.
let's say you've got hypertension, you've got diarrhea, you've got headaches, you've got flushing. It could be carcinoid syndrome, in which case it is enterochromaffin cells involved, and it's serotonin that is involved and not mast cells. And unfortunately, some of our colleagues say that chromogranin A is released from mast cells. It is not. It's released only from chromaffin cells or enterochromaffin cells. And not only that, for those who are listening there, but you have to be off all antacids if you measure chromogranin A. Otherwise, you turn out to be false positive. So there are a few things that we have to worry about as we worry about the fact that whenever we measure the metabolites in the urine, and we can go over those metabolites in a few minutes if you wish, the urine has to be collected cold, stored cold, reach the laboratory cold, and the technicians better know they have to actually process it cold. If it stays at room temperature for about 10 minutes, it's gone. You can't measure the metabolites, and we get all these results. Oh, it was negative. There's nothing there. So there are a lot of these tricky things.
So I was thinking of in terms of connecting the dots. I know that mental brain fog can be from other symptoms. A lot of the patients have POTS or dysautonomia, and so they have brain fog. But in this category where we are connecting the dots or jigsaw puzzle and the pieces fit.
Well, let me step you for a second. The pieces don't necessarily fit. And as I might have said with Linda in the previous episode, I'll say it again, I tell patients, go in to your physician with about 5 symptoms top. The moment you start reaching 10 and 15 and 20 symptoms, they're going to think you're crazy. And they just won't know what to do, and it's too confusing, and it's too time-consuming, and they're not going to do anything. So if you start focusing on brain fog on a patient with otherwise, mast cell activation symptoms, they're probably going to say you're for the birds. Seriously, I've seen that so often that, I will take the information down, but I would not necessarily make it an absolute critical part of getting through the door. Okay, when mast cell activation syndrome first was reported by Metcalf, Akin, and Valent, they did have neurologic symptoms, and it was music to my ears because I've been studying brain mast cells for 30 years. But then subsequently, they took that off. Okay, so maybe for the reasons that we're discussing, or maybe they just got tired of people showing up with the neuropsychiatric symptoms and not necessarily other symptoms. So we'll go back and forth. I'm not being negative. I'm just trying to.
So can we divide it into major criteria and minor criteria?
I wouldn't call it criteria. I would call it major, minor symptoms, or major and ancillary symptoms. I don't like the word major, minor, because in some people the minor might be major, and in others might be the other way around. So, but definitely it's got to have at least one of the sort of more classic symptoms, whether it's itchy eyes, itchy nose, flashing, skin itching, some gastrointestinal problems. Those are kind of the more typical things we see, although it can be any organ.
So I have a major criteria. Okay, the major criteria is flu-like symptoms.
Okay, well, why would that be a major criteria since flu-like symptoms can happen for 20 different diseases? Why would that be a major criteria?
If they don't have a disease, if they don't have a viral condition
or a
bacterial
we will not know
condition,
that until we, of course, investigate that. Someone comes in with viral symptoms. Anyhow, it's hard for me to call that a major criterion when it's prevalent in so many other conditions. I would start with the ones that definitely are associated with mast cells, and yes, that.
So that would be skin flushing, itching, multiple chemical sensitivities.
Yeah,
these would be
maybe diarrhea, GI
criteria.
symptoms. That's what I would call major, and that everything else you said is there.
So GI symptoms being abdominal bloating and acid reflux.
Well, acid reflux, there's a separate diagnosis, and the gastroenterologist will give you a separate diagnosis for that. So yes, that comes in mind. But you can have acid reflux because you've got Helicobacter pylori, not necessarily mast cells.
So among the GI symptoms, bloating would be one of them, right?
Bloating would be one. Abdominal pain off and on would be another. And then alternating constipation, diarrhea, which is very similar to IBS. And I've published papers that I think IBS is literally based on mast cell activation in the gut.
I am so glad you said that. Thank you so much.
Well, I'll say other things that you might like in a second. But you see, the difficulty becomes, and one of the papers I wrote about IBS is that number of mast cells is not important. It's the activation of the mast cells. Because many of our colleagues will look in the gut, and I've been in an endoscopy suite with patients of mine where my colleagues, the GI physicians, will try to find, where should we look? So we will be looking the endoscope together, and most of the time there are no lesions to biopsy. So you don't know where to biopsy. Dr. Miner many years ago said that most of the mast cells are in the ileocecal junction. So I usually say, okay, let's biopsy there, and then you take random biopsies. But what I do, and we might talk about this in the objective criteria, is I actually request to send stool for 3 analysis of three things. Total histamine. Why? Histamine systemically is broken down with 1 minute, and it will end up in the urine as N-methylhistamine or MIAA, methylimidazole acetic acid. If it is released from the gut, it shows up in the gut, in the stool. It doesn't get broken down because the enzymes that break down will not have enough time to actually work on it. So if I have severe GI problems, histamine in the stool is off the roof, total histamine. Then I measure eosinophilic cationic protein or eosinophilic protein X. Both of them go hand in hand with mast cells, and they're very strong triggers of mast cells. And we don't necessarily have to have elevation of absolute numbers of eosinophils in the blood for these proteins to be high. So I measure that as an index of the mast cells being activated by something that I can put my fingers on. And then I measure calprotectin, which is a good index of inflammation. Okay?
Yeah.
So those three, just to make sure that if those are high, then I'll tell GI people, go and look for some that who might have GI mastocytosis. And then the question is, how do you define that? I know we're going in an angle for a second, but we'll come back. Because most colleagues say it's got to be between 20 and 30 mast cells per high power field to be pathognomonic of something. 10, 15, it might be okay. But again, you can have 10 mast cells firing like crazy. You might have 50 mast cells that don't do anything. So it's not enough. That's why I ask my GI colleagues when they biopsy to stain for both tryptase and c-KIT or CD117. Why? c-KIT is on the surface. It will not change whether the mast cells have degranulated or not. But tryptase will come out and the granules will be empty. So if you have, let's say, 100 mast cells with c-KIT and they're all positive for tryptase, that means they're not degranulating. They might be releasing with other means, but they're not frankly degranulating. If they're empty, that means they spilled out their tryptase. So that kind of gives us an index of at least rough degranulation of mast cells, which is true not only in the gut, it's true in the skin or anywhere else you might want to biopsy. Anyhow, back to the clinical science.
So I have a follow-up to that. Real quick. So these three stool tests that I think some of these you mentioned last time is really important. So stool, histamine, eosinophilic cation protein, and calprotectin, right? Those
Correct.
are the three that you mentioned.
Correct.
Okay. Can those be, number one, done just through a regular lab, or does it have to go someplace special? And number two, are these, if they're positive, then you mentioned mastocytosis. So would you be concerned about mastocytosis then, or could those be positive in mast cell activation?
Those are excellent points. On the first point, both calprotectin and eosinophilic cationic protein are measured by typical labs like Quest and LabCorp and whatever you. Total histamine in the United States is not measured routinely. In Europe, most of the labs do it. I don't know why. So that might be a little bit of a problem. But I don't think Quest and LabCorp measure total histamine in the stool. So you might have to go to a special lab. So the first thing that is telling me is that the muscles are being activated in the gut. Now it could be, and of course, whenever we send stool, we do, ova and parasites, of course. So it might be a parasitic infection that maybe we missed. So I would usually ask, especially for children, do they eat around the anal, opening? Because most of the parasites, come out at night, deliver their eggs in that area. And, when I was at Yale studying medicine, we used to use a tape and just, pull the eggs off the tape and look at them under the microscope. Okay. So that might be a possibility. And some parasites, it's impossible to see, like Giardia lambria, you can't really see. You've got to actually put in a drop of, fluid and see if they swim. But who does these things? A long time ago, we used to do them. I don't think anybody does them anymore. So when we ask for ova and parasites, in all honesty, I'm not quite sure what kind of parasites they're looking at, whether they're looking at the waterfront or not. Now, more and more now, the laboratories that they do, of course, the whole microbiome in the gut, as they do it in other places like the bladder or the vaginal vault, etc. That might be a way to go without going to extremes at some point, because that might indicate that there are actually species there that we just didn't pick up with a regular, ova and parasite test. Now, if those are negative, then one would suspect intestinal mastocytosis, not systemic mastocytosis. Now, in intestinal mastocytosis, not very many colleagues believe in that because they cannot find the mast cells. But there are papers, especially in children. I had one child from Denmark a long time ago that was going to be taken by social services because he couldn't eat. He was constantly, diarrhea, couldn't eat. And eventually I had to bring him to Greece, of all places. But they did the biopsy and it was about 40 mast cells per high power field. The kid had absolutely GI mastocytosis. And then we kind of did whatever we did, etc. So that part is hard. Now, if we talk about systemic mastocytosis, as you know, it's all the symptoms that Dr. Chopra mentioned earlier, but tryptase is almost invariably elevated no matter when. So if you've got a high elevated tryptase and these symptoms, you're not dealing, with just muscle activation anymore, in which case there are either one of two things one can do. Either you can do flow cytometry on peripheral precursor mast cells that express the receptors such as CD117, CD23, etc. But you've got to have a very good flow cytometry and, antibodies for those antigens to pick it up. Otherwise, you do bone marrow biopsy. And I'll stop by saying no one should do an aspiration. Just the sheer force of aspirating will degranulate the mast cells. So it's got to be a biopsy. And then we're not looking at 5, 10, 20 mast cells. We're looking at clusters, islands of like 50 mast cells, etc. And the shape is spindled rather than round. Anyhow, go back to.
So you just referred to mastocytosis, not mast cell activation disorder.
If tryptase is very elevated, regardless of the timing, remember in mast cell activation syndrome, tryptase has to be elevated within 48 hours of an episode. In systemic mastocytosis patients, tryptase is elevated regardless, every day. Yeah. You don't have to have an episode. It's just high because it measures, it's an expression of the number, the volume of the mast cells you have, not their activation. And at some point we should talk about hereditary alpha-tryptosemia because it's very, very confusing, but maybe later.
You know what? That would be a perfect. We're going to take a quick break, and when we come back, let's talk about hereditary alpha-tryptosemia because you're right. It's very confusing, and I want to make sure that people get a little bit of an idea of what that is. So we're going to take a quick break, and we will talk about that when we come back. This episode of the Bendy Bodies podcast is brought to you by EDS Guardians, paying it forward in the Ehlers-Danlos syndromes community, patient to patient for the common good. I am proud to serve on the inaugural board of directors for EDS Guardians, a small charity with a big mission and a big heart. Now seeking donors, volunteers, and partners. Patient advocacy and support programs available now. Travel grants launching in 2025. Learn more, shop for a cause at their swag store, and join the revolution at edsguardians.org. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube, and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. Okay, we're back with Dr. Theoharides and Dr. Chopra. Okay, go ahead, Dr. Theoharides. I think you had something very valuable to say.
I was going to say that the first thing is how do we educate, and I mean it in the good sense, the general practitioner, the internist about these things. Because what will happen is if someone sees these symptoms, they're going to send them to an allergist. Mm-hmm. Very few people, maybe unlike you and me, and Linda, will actually deal with these patients. Mm-hmm. And that's why I think we should join forces and write a very good article for Journal of Family Practice. Seriously. I just Googled it, and there's hardly anything on mast cells.
Let's do it.
Because these are the kind of journals, there might not be, significant journals, but we have to get to our colleagues who are likely to see these journals because they're not likely to look at, JACI journal or, allergy journals or whatever. Okay? And we usually all publish in the more esoteric journals because they have, better impact factors and what have you. But we've got to get to the very basic at this point. So having said that, how many do you think general practitioners or internists are likely to deal with MCADs rather than sending someone to an allergist? Let's just throw a percentage.
In my area, there's no one.
There you go. Same with me.
No one.
Mm-hmm.
So even though my heart bleeds for how to educate, and in the good sense, educate our colleagues, at the end of the day, they're not going to deal with these patients for all kinds of reasons. And now we're going to the allergist. How many of the typical allergists do you think know about what we're talking about?
One.
Very few.
In my entire state, there's only one.
Very few.
Very few. Unfortunately,
very
it's
few.
very few.
And I think I might have mentioned in the last episode, but I will reiterate it, about a year ago or so, maybe less, a relative of one of my previous doctoral students, physician himself, who was actually vacationing in Tampa, in Florida, had to go to the emergency room because his wife had an anaphylactic reaction. And she already had a history of MCAD. So now this was related to me by her husband, the physician. They went to the emergency room and they explained that, she's got a history of mast cell activation problems. And the attending physician, he might have been a resident or some serious attending. The first question was, what's wrong with your breasts? Because she said mast cell activation. This is 6 months ago in Tampa. Okay? So the issue is very, very difficult and very important. And that's why we should try to clarify this as much as possible, even though we would love to be talking about all the complicated aspects thereof. So we've got to sensitize the physicians that patients who basically are allergic to life have MCAD. And if tryptase is elevated within an episode, they've got MCAS. That's it. Okay? Let's call it this. But I don't like the word allergic because allergic, again, as I said earlier, implies IgE. Yes. So sensitive to everything, like multiple chemical sensitivity type of patient with no other explanation.
So these patients will present with, sore throat.
Okay.
Most times when I examine their throat, it's red and inflamed.
Okay, so you do a strep test quickly.
But they don't have any complaints.
Well, they have sore throat. That's a complaint.
They don't complain about that. That's the thing.
So what do you mean they have sore throat then if they don't complain?
So is that the sign of, among other signs, would that be one of the symptoms of or sign of MCAD?
Sore throat by itself would not necessarily trigger me. But if they have swollen lips, redness around the lips, swollen tongue, then absolutely yes. And then we have another syndrome. We're covered with syndromes, red tongue syndrome. And then we've got, geographic tongue, et cetera, et cetera. Many of them overlap. And since you mentioned that, and again, I might have mentioned this before, Linda, I apologize, but one of the things that is becoming more apparent is individuals who actually get swelling around their lips. And I had a wonderful lady actually from Boca Raton about a month ago that not only would have this swelling, but her whole face would swell up so much. She was literally a model. And if you saw her face, you think it was like out of, some horror movie. It was that bad. I've never seen that swollen a person. And as it turns out, after digging into it, she literally had what we call alpha-gal syndrome, which is another thing that we should talk about in addition to alpha-tryptosemia. So in alpha-gal, as we all know, of course, it's an antigen. It's present in mammals, but humans don't have very much. So it's much more present in cows and pigs and, et cetera. And if you're bitten by a tick, you might not get Borrelia or Babesia or some other, bacterial disease, but they will carry the alpha-gal to you. And now you become super sensitive to it, and you become super sensitive to anything that has mammalian product, including drugs, supplements, and cosmetics. And her mascara that she was using had actually gelatin in it, which was actually of course, from mammalian source. And so we responded to that.
I have a question on that alpha-gal syndrome. It's only to beef and pork, right?
Correct.
Not to
Not
chicken and
chicken and
fish.
no fish. No.
No fish, right?
Correct.
Okay.
However, now that you mentioned it, carrageenan, which is used in many capsules of supplements and drugs, the clear cap is made of carrageenan. Carrageenan from seaweed. Carrageenan cross-reacts with alpha-gal. You can look it up. So someone could be reacting even to the hard gel caps of drugs and supplements, and we just don't say that. That's why I'm saying we're making life more complicated if you wish, but at least there's specific things that are measurable.
So if a patient comes in with saying that, doctor, I am allergic to meat, beef and pork, but I'm okay eating fish and chicken, then
that's a good indication. That's a good. But you see, the patients are not going to say allergic. They're probably going to describe
They're going
something.
To say, react to it.
React to it. Yes, yeah. I would definitely think of alpha-gal.
And we can send them to Quest or LabCorp asking for alpha-gal antigen.
No. What you ask is just like when we ask for, if we do an allergic panel, and unfortunately, many of these companies have panels. You can't ask specific. You can ask specifically, but it's more complicated. So they have, for instance, allergen panels. They have food panels. So it's probably going to be under the food panel before, so if you search for alpha-gal, you might be able to find it. But if you look at a food panel, it might be listed underneath.
It'll be there. Okay.
Yeah. So I usually but we'll talk about the specifics in a second, what we measure. But yes, I would measure that. And then, of course, food sensitivity is a whole different ballgame that we can talk about later, because food sensitivity is immunoglobulin G subclass 4, IgG4. It's not IgE. And the mast cells are triggered through IgG4.
Just before we leave meat alone.
Sure.
If you eat reheated meat.
Yes.
Meat that has been put in the fridge and then the next day you reheat it. The histamine level goes up, right? Because the DAO comes down.
I have seen that happening with fish, not so much with meat, to be honest. In fact, I tell all patients, don't reheat your fish. You eat it, you throw it away. Because
but not with meat.
I haven't seen it as much. I mean, I usually say if you can eat it fresh, it's better. But if you were to ask me to put my finger in a publication, with meat, I don't have it. With fish, I do.
Okay. Yeah. When you say fish, you mean fish that swims and
yes,
scallops
not those.
Or shrimp and all
people
that.
might be allergic and sensitive to those regardless.
That's different. Yeah,
that's different. Okay. But we should talk about diamine oxidase later. So maybe Linda can make a list of all the things we should cover.
Yeah, we did talk about that in the first part. So I think I would love to talk about hereditary alpha-tryptocemia, because we could talk for hours and hours and hours, but I don't know if there was something else more pressing on someone's mind before we transition to that, because I know we kind of went from like symptoms and
we didn't cover the objective measurements.
Right.
So maybe we should say a few words about that before we go to the other.
And that kind of folds into, because we're talking about tryptase and then the objective measurement for the hereditary alpha-tryptocemia.
So I always ask for total IgE, total IgG1 and IgG4, because usually it's a yin-yang. The IgG1 tends to be the good guy, IgG4 is kind of the bad guy. I will measure a plasma histamine, but it invariably is going to be very low, unless someone has chronic itching, so chronic idiopathic urticaria. And that is important to measure the plasma histamine, because in about 50% of the patients, the plasma histamine is high. If it is high and someone doesn't have an anaphylactic reaction, I'll think of chronic spontaneous urticaria, because about 50% of those patients have an autoimmune condition where they make antibodies against either the IgE receptor or the IgE itself, and those are gain of function. They stimulate the mast cells. And that test is called basophil activation test, because we cannot isolate the mast cells to test it, but we can isolate the basophils. Now, that is buried onto the chronic pruritus panel in Quest. So you can't look for basophil activation test or anti-IgE receptor antibody test. It's a chronic urticaria panel, and it's listed underneath. And within the chronic urticaria panel, they also have antithyroid antibodies, God knows why. So it's not really, it's kind of confusing.
I'm very interested in that because I have chronically elevated histamine and I have antithyroid antibodies and I do have chronic itching. So
right. There is an association, but I'm not sure I would call that MCAS or MCAD as of yet.
Mm-hmm.
But for instance, I would be more interested in parathyroid hormone measurement if someone has intractable itching, because PTH is one of the strongest triggers of mast cells. In about 1 in 20 patients I've dealt with chronic such problems, including an unfortunate but wonderful little kid that has both mast cell activation and autism and Down syndrome, and he was itching himself like crazy, and no one believed that there might be PTH. PTH was off the roof. Okay? Now, it could be primary or secondary PTH, parathyroidism, but it doesn't matter. It will stimulate the mast cell. So we have to drop it down, whether you give calcium levels so you can lower it, or you take some of the parathyroid glands out. So I will measure those for that reason. Then I will ask for a food intolerance test. But there's a caveat there. If you eat something every day, it turns out to be false positive. So I usually say organic boiled chicken and rice. I've hardly ever seen any reaction to chicken, and rice doesn't have gluten, so we're kind of on the safe side. So if you do that for 3 days, then you do the test and I'll sort of believe the results. Okay, so that's food intolerance IgG, not IgE. Then there's certain molecules that come from the mast cells, other than tryptase, that would be important to measure, especially if there's some other telltale signs. For instance, tryptase is stored in the secretory granules of the mast cell together with another enzyme called chymase. Chymase converts angiotensin 1 to angiotensin 2, and not only converts it, but it's resistant to the drugs. So if someone has very high blood pressure that's unexplained, for instance, I will measure chymase for that reason. IL-6 is definitely coming from the mast cells, and both Dr. Metcalf and colleagues, Dr. Escribano in Spain and colleagues, and I, at different times, different journals, published that IL-6 elevated in the blood was a better indicator of mastocytosis severity than even tryptase. But hardly anybody measures IL-6. Why? Because it can come from other cells. But going back to what Chopra said, if no one has no other condition and IL-6 is high, then I'll be damned not to consider that it might be coming from the mast cells. If someone has inflammatory bowel disease, well, yes, it could be coming from that. Okay? So I'll measure IL-6. I will definitely measure vascular endothelial growth factor because it comes out of the mast cells, and it comes out of the mast cells without necessarily histamine or tryptase. And it is incredibly important under stress. We've published numerous papers, and so have others. The corticotropin releasing hormone, first hormone released under stress, which we always thought and taught it's only released in the hypothalamus. It's released in every organ in the body. We've published papers that chronic itching in eczema and psoriasis had CRH elevated both in the skin and the blood, for instance. And other colleagues have shown it in the bladder, GI tract, etc. And when CRH stimulates the mast cells, they release only VEGF, no histamine or tryptase. And more recently, a paper was published that in systemic mastocytosis, angiopoietins, which is like vascular endothelial growth factor, but there are about 5 other angiopoietins, were very high. And the German group has shown that heparin is also quite high in systemic mastocytosis patients. And keep in mind, half of the granule of the mast cell is actually chondroitin sulfate and heparin sulfate, and yet the mast cells don't circulate. So obviously these molecules do something else. And the reason I'm saying that, because if I see, coming back to what you said, Dr. Chopra, earlier, bruising, and of course, if it's not, trauma or abuse, whatever, I might think that the muscles are spitting out heparin, because heparin is anti-clotting, it causes bruising. And we've seen that in some cases of aggressive mastocytosis. Now, why heparin would be released and not other molecules like tryptase, it still baffles me, because we've been taught that they're all in the same granules. Maybe they're not.
So in MCAD, do you think we should measure heparin?
Laboratories in the States don't measure it. In Europe, they measure it. Now, you can measure it indirectly, you can measure it, but I don't think anybody measures heparin as such. But if I see bruising, I'll do all the testing that are likely to tell me if there's actually, bleeding diathesis of some sort.
Right.
Okay? So that's pretty much in terms of blood measurements. And then we go to the urine measurements that we mentioned earlier, which would be either N-methylhistamine, which is the breakdown product of about 30% of the histamine, or MIAA, methylimidose acetic acid, which is another 60%. And both I and Dr. Butterfield and others believe that one measurement is not enough, because these are episodic. Histamine is released episodically, as you know. You might have a reaction and, tomorrow might not have a reaction. So I usually measure it, at least twice within 3 months. And then, if it's not high, it's not high.
And when you're doing the urine tests, are these spot urines, or is this a 24-hour urine collection?
It used to be 24-hour urine, but Dr. Butterfield at the Mayo Clinic said that first morning void might be sufficient unless someone has interstitial cystitis or they have enuresis and they're up all night, urinating. And I think it's fair, first morning void.
Does it matter that the patient is on mast cell stabilizers or antihistamines?
You asked that earlier, and it's a very good point. So antihistamines block the action of histamine after it's being released. So it's not going to make any difference to the amount of histamine. Now, there are some antihistamines, like rupatadine, which is available in Canada and in Europe, that also blocks the mast cells to some extent. So if you were to tell me someone should be on rupatadine today, I'll say no. But if someone is on Zyrtec or, one of those, it doesn't make a difference. The same way will not make a difference with Singular, because it blocks the action, not necessarily the production thereof. Definitely they should be off steroids, because steroids will block the production of everything. So that's one. And number two, they should not be on any foods that contain, of course, high amounts of histamine. And that takes us to another topic, which is histamine intolerance. Okay? Because foods, as you know, like fermented foods, cheese, tomatoes, spices, avocado, pineapple, have a lot of histamine, cumin, curcumin. So, and sometimes colleagues will give actually a flavonoid because it's anti-inflammatory, anti-allergic, but unless it's 98% pure, it's going to have a lot of histamine. Curcumin has histamine, cumin has histamine, cinnamon has histamine. Okay? So, and I see all these, dietary supplements, immune support, they have about 10 different things in there. And, unless they're pure, I say, my God, who knows what they do.
So you said pineapple has a lot of histamine in it?
Mm-hmm.
So quercetin, I thought, was made from pineapple, right?
Well, that's why it depends how pure it is.
Oh.
And unfortunately, what you see out in the market, give you an example. You can either try to buy quercetin or luteolin, which is more favorable in my mind than quercetin, or the combination, and you see a price of $20 for a month's supply. And I said, bullshit, excuse the expression. I know how much it costs to buy a kilogram of this in 98% purity. There's no way on earth that someone can be selling 60 capsules with 500 milligrams per capsule at $20. They're just lying. Okay? That's it, period. So, cost alone should not be the determinant factor for, either patients or physicians. And I've got many colleagues who call me, well, why should we get Neuroprotect? It costs, I don't know, $35 and not SATs. And what I do, I send them the analysis, because I send both for analysis to Eurofins, and one comes 50% purity and the other comes 98% purity. And if it's not pure, what the hell does it have in it, like histamine? In fact, one of the cheapest sources of quercetin is actually peanut shells, but they don't tell you that. So if you're allergic to peanuts, you're doomed. Or fava beans. But 20% of Mediterraneans have G6PD deficiency, and if they fava beans, they get hemolytic anemia. Who tells you that on the label of the stupid dietary supplement? Okay, so don't get me going on the supplements. It's insane, because it's like billions of dollars are spent all over the world for supplements, and maybe 10% of them are worth anything. So, but it is what it is. As you probably know, Amazon announced that as of May 1st, I don't know how strongly they will actually implement this. Any dietary supplement sold moving forward on Amazon will have to be analyzed by 3 laboratories that they actually selected, one of which is Eurofins. So they will send it to Eurofins, they'll get the results, and if the results are not within 50% of what you claim on the label, you're out. The FDA should have done this a long time ago, but they haven't. And they're not likely to do it either. So, all right, yes. Back to alpha tryptophanemia.
Yeah, because we definitely want to talk about treatment, and which you kind of were talking about when you were talking about supplements.
So alpha tryptophanemia. So as I said earlier, in the study that was published, and the first report was by Dr. Lyons at NIH, they found out it's a genetic condition where you actually make the alpha type of tryptase. And let me explain what that means. Inside the secretory granules of the mast cell, you have a beta tetramer, beta tryptase tetramer. It's inactive inside the granules because it's bound to chondroitin sulfate and heparan sulfate. The moment the granules release, that gets dislodged, and now tryptase is active. We still don't have a drug to block the action of tryptase, but it is active. Now, in this condition, it is alpha-2. It's a dimer, not a tetramer, and alpha-2 is inactive, and it is not inside the granules. So question number 1, where is it coming from if it's not in the granules? Question number 2, if it's inactive, why on earth do these patients have almost all the symptoms of mast cell activation patients? I have no clue. And I don't think anybody has, for that matter. Okay? So, if in fact someone has tryptase elevation without necessarily having all the symptoms, which is very hard to discern, then you might think, or if someone is telling you as you take the medical history, oh, you know what, my aunt has similar problems, my daughter has similar problems, then it's worth doing a genetic analysis for the gene. Okay? How will we treat this patient? Probably the same way we treat anything else, and we will get to that. But I'm not sure what I'm treating because, as I said, alpha tryptase is not in the granules, and I don't know how it's coming from, so it's wishful thinking, if you wish. But it's becoming much more common. Now, according to Dr. Lyons, about 8% of the population has hereditary alpha tryptophanemia. That's a very high number.
Very high number. So the symptoms of alpha tryptophanemia is almost the same as MCAD?
Almost. So there are a number of tables that we can look at, but they do have itching, and they have a lot of GI problems. Not so much flushing, and not so much the neurological problems. So if I were to give it a number, in MCAD, the neurological problems, at least in my book, might be 70% of patients. In tryptophanemia, might be like 5%. But skin is about 70%. GI is about 70%. And clearly tryptase binds to protease activated receptors, PARs. So it might be that the alpha-2 binds to a different PAR receptor and causes these problems, and tryptase binds to a different receptor. But we don't have a way of blocking either the release or these receptors, at least not for the time being.
So can we go to treatment?
Sure. So invariably, we start with an antihistamine. And invariably, we like the non-sedating or second-generation antihistamines. And invariably, we can go 4 times up the recommended dose. So let's say cetirizine is 10 milligrams, we can kind of slowly bring it up to 40 milligrams. But the moment you start going upwards, you're likely to get sedation. So that's one. Second point is that about 15% of patients don't get sedated, but get wired. So they get very anxious and they don't like it. And I don't know why they get wired. I mean, I don't understand the pathophysiology, but they get wired. Third point is that all of the antihistamines in the first generation, like Benadryl, like hydroxyzine, are more of what I'm about to say, are also anticholinergic. So they block acetylcholine receptors. And therefore, if you start pushing the dose, you might put someone in retention. They might not be able to urinate because they're anticholinergic, or they might not sweat as much anymore, or they might have dried eyes and dry mouth, and you might start thinking Sjogren's syndrome because of that. So keep that in mind. Also, at very high levels, like over 100 milligrams, I would never give them on people that have a history of seizures because they increase seizure activity as well. And even though what I'm about to say was true for the early first generation antihistamines, it's been creeping up for cetirizine and hydroxyzine that might actually increase the QTE interval. So cardiologists, worry. And if we have someone that has actually QT elevation, then I might go very slow on the dosing there. Okay? So that's for H1. Now, anytime you have a chronic problem, whether it's itching, gut problems, etc., you're going to be stressed. And of course, we're swimming in stress, whether it's political, financial, what have you these days. So your histamine is going to be stimulating the parietal cells in the stomach to make acid. So we've got to block those. So I invariably give a histamine 2 blocker. And of course, there are issues with some of the blockers, which I'll mention in a second. And there's another reason why, which is not very well known. The mast cells have H2 receptors on their surface. And histamine activates the mast cells through the H2 receptor. So by giving an H2 blocker, not only we reduce the amount of acid produced, but mildly keep the mast cells from overfiring. Now, there are issues. As you know, the first drug, cimetidine, which was very popular and it's over-the-counter, of course, Tagamet, it inhibits the P450 system in the liver. And because all of us, and I mean males, have a little estrogen, if you block the P450 system, you build up the estrogen and you get gynecomastia and loss of libido and loss of erection. So we've got to tell patients if they go on Tagamet, you've got to watch out. Likely it's reversible. Now, the others like famotidine, ranitidine are a little better, even though there was a little scare about some other side effects, but they're still on the market. Now, individuals who have chronic gastritis or chronic GERD, I would worry about H. pylori. And as I said earlier, H. pylori likes acid environment and is very difficult to eradicate. So if someone has chronic GERD, you've got to actually think about either doing an endoscopy or breathing test for H. pylori. And the treatment is 2 antibiotics and 2 antacids for about 2 weeks. However, there's GERD that is eosinophilic esophagitis. And in eosinophilic esophagitis, we're looking at eosinophils. I always urge my colleagues to look for mast cells because I said earlier, they go together. Same thing as eosinophilic gastroenteritis. Again, I worry about mast cells in both of those conditions. So those are kind of the beginning. So then if you've got lots of itching, before we talk about chronic spontaneous urticaria, you've got to give over and beyond what the antihistamines can cover. You might give a steroid cream if it's localized, or you can give a cream that I helped develop called Gentle Derm that has actually tetramethoxyluteolin, which it's very well tolerated. There are a couple of publications, and you can use it together with an antihistamine. If you've got GI problems, then you do the food intolerance, of course, testing that we spoke about, or the food allergy testing. Then you might consider DAO, that we spoke about last episode, diamine oxidase. Just keep in mind that diamine oxidase will be destroyed in the stomach. The stomach has acidity of 1. Enzymes work at an acidity of 7, just like our blood. So I like 1 or 2 that are actually acid resistant or enteric-coated. And I think I sent you that list, Linda.
Yeah, you sent it to me. And I'll put it in the show notes so people have it. Yep.
Okay. So now what do we do then? Then is where I look for natural molecules that might block the mast cells. And, quercetin can block the mast cells. Luteolin is a little better. And we published that both quercetin and luteolin are better than cromolyn, the only drug that is sold as a mast cell blocker. And there are issues with cromolyn. Number one, the new preparation in the United States is horrible. It causes all kinds of problems. Hardly anybody can tolerate it. I don't know what on earth they did, but it cannot be tolerated. Number two, it shows a rapid tachyphylaxis. The body gets used to it. So we started about 100 milligrams, once, twice a day. By 3-4 months, we're 400 milligrams 4 times a day. Stops working after that. And then you start getting about 15% diarrhea, but 10% alopecia. And Dr. Church in England published 2 papers that if you push the biphasic curve, you start stimulating the mast cells to release histamine. So if I don't get any results by 400 milligrams 4 times a day, that's it. Go cold turkey, stop it. It's not going to do anything more. So then what do we do after that? Well, we measure the mediators. If leukotriene is high, singular. If prostaglandins are high, some kind of NSAIDs if it's tolerated. And then we go to what is left in terms of symptoms. If it's a lot of itching, neither the so-called biologics, of course, are injectable, but Dupixent blocks, for instance, some of the cytokines that stimulate also mast cells. Now there's an IL-31 inhibitor, and IL-31 is more pruritogenic than histamine. So that's now available on the market. And of course, there are 3-4 new biologics that block the receptor for interleukin-5, which stimulates the eosinophils. So for chronic asthma, eosinophilic, esophagitis, etc., those drugs might be good. But you see how we're now limiting ourselves to specific symptoms, not the overall. So the overall is not going to be helped by these drugs, but the itching would be. And then we have those patients that we mentioned earlier that might have autoimmune chronic spontaneous urticaria because of antibodies. What do we do for those? Well, very little. In those cases, either we use, and God knows why it works, immune IG, IVIG, or sub-Q IV, which seems to work, but I don't know why it works. Or we use low-dose naltrexone, which also works, and I don't know why it works. So by LDN, we mean 0.1 milligram, which incrementally is increased over like 2 weeks to no more than 4 milligrams a day. And by 4 milligrams, if it doesn't work, it's not going to work. And patients experience kind of nightmares and all kind of, other such symptoms. That's it.
We forgot ketotifen.
I thought you'd ask. Well, ketotifen is a misnomer. Ketotifen is a very good antihistamine. It's not a mast cell blocker. The only publication that ever showed that ketotifen blocks anything was in conjunctival mast cells, single publication. But ever since that time, everybody calls it a mast cell blocker, and it is not. Yeah. Rupatadine is a mast cell blocker. There are 5 publications. Now, having said what we said about antihistamines, some antihistamines work better than others. So I would not give up, and ketotifen would definitely be up my sleeve. Not because it's a mast cell blocker, because it's a different antihistamine, and some people tolerate it and do well, but it's very sedating, and it causes increase in appetite, just like the tricyclic antidepressants, back then. So sure, we would use it, but it's not a panacea. So I would put it probably in the category along with the quercetins and the luteolin, etc. But before we leave the topic, I just want to mention that all flavonoids are not necessarily good. And luteolin quercetin, of course, is a flavonoid, so is resveratrol, so is curcumin, etc. So you see soy flavonoids, for instance. Well, God forbid if someone has estrogen-dependent breast cancer, they will actually increase the cancer because soys are, estrogenic. So we've got to, be a little smart about what, of course, patients cannot, make out the difference, but I'm just saying.
So the mast cell stabilizers are only cromolyn?
Cromolyn is not a mast cell stabilizer. I published the first paper on cromolyn in the journal Science as an undergraduate at Yale, and I'll brag about it. But it worked like a charm in rats. Dr. Galli, who is chief of pathology at the University of Stanford, he used to be, you may remember him, at Beth Israel, actually, before he moved to Stanford, he published that it doesn't even inhibit mouse mast cells. And as I said earlier, we showed that cromolyn and luteolin are much better inhibitors than cromolyn. Now, I give credit to cromolyn, though, because as a student at Yale, I used one of the first programs NIH had for comparing basically molecules. And why did I find actually luteolin and quercetin? Because cromolyn looks like a butterfly with 2 wings, and the flavonoids are a butterfly with 1 wing, with 90% accuracy. So when I was looking at natural molecules and I saw the structure, I was stunned by the fact that they're very similar. But to this day, No one has identified a receptor either on the surface or inside the cells for chromoline. We have no idea.
Just to clarify,
Sure.
if I'm going to treat a patient with MCAD,
Yes,
I start with H1 blocker, H2 blocker.
correct.
What would be my third drug?
So as I said, if leukotrienes are high in the urine,
So you
then
go to
you will just
Montelukast.
right. If prostaglandins are high, you'll give them a little of of NSAIDs, and then either at that point or from the very beginning, you give them liposomal luteolin or liposomal luteolin and quercetin and quercetin together.
Got it.
Because they will block the mast cells, but it takes weeks before the mast cells really calm down. It doesn't work like an antihistamine, like overnight, your hives will disappear.
Right.
And then you start tolerating foods. You start tolerating exposure to some, other triggers, etc. I wish we had better drugs. We published a paper just a couple of weeks ago where 2 newer flavonoids are even better, or we tested them so far on microglia, not on mast cells. We are in the process of doing that. So those might be even better, and one of them is partially water-soluble, which makes it better.
Yeah. Oh my gosh. We could talk about this for really a long time. This is such an incredible conversation.
Linda, there is a condition that we should touch upon, or maybe Ann Maitland should do it. But there's periodontitis now in a subgroup of patients with EDS. And we've published a lot of papers about mast cell periodontitis. So maybe we should talk about that some other time. It's an incredible new entity now that I don't quite understand as of yet.
I have discussed that with her, but not during a recording. So we'll have to figure out how to have that conversation.
Maybe you should bring Ann and myself back.
Yeah.
And Dr. Chopra.
So I have a question which is a little bit out of the box.
Sure.
Now, in MCAD, we know that there is extensive metabolism going on, and there's a lot of free radicals that are in the cyst in our bodies.
Okay.
Is it worth? But are there free radicals? First, I want to ask you that question.
Well, anytime we have inflammation, we have oxidative stress.
We have free radicals, right?
So that goes without.
So would like antioxidants or free radical scavengers be a good idea?
Sure, it would. It would be no harm done, and besides, both quercetin and luteolin are antioxidant. In fact, they were identified anything that's color, like up in the New England where the leaves change color, it's all flavonoids that do the color, and they protect the tree eventually. So what it is the more phenolic the flavonoid is, the more antioxidant it is. So pycnogenol has 15 hydroxy groups. So it's much better antioxidant. The quercetin that has 5, the luteolin that has 4. Okay? But the more methylated they are, the more anti-inflammatory they are. So tetramethoxyluteolin that is present in the gentle term that I mentioned earlier is actually a better anti-inflammatory molecule, and it's an antioxidant as well, but doesn't have color because it doesn't have the hydroxy groups. So it's a yin-yang, but there are many. Well, if I have individuals, especially children, with a lot of neuropsychiatric problems, there might be autism, there might be ADHD. Not that I see the children myself. Usually the parents bring them because they have a problem, and then they tell me about the children kind of as well, as it happens. But then I might measure glutathione levels because our body has the only antioxidant that it has, it's glutathione. Now, some laboratories don't measure glutathione, but they measure glutathione peroxidase, which is kind of the same idea. If that is low, then I'll give them glutathione. And it's you can give them, of course, herbal supplements like the ones we spoke about, and vitamin C is an antioxidant as well, et cetera, et cetera. But I might give them glutathione. It's a spray, it's sublingual, and it's by mouth, and it's injectable as well. So that's another kind of approach. But that would be, again, a subclass of individuals that have more neuropsychiatric problems.
Got it.
Now, before we leave, there are publications that berberine also blocks mast cells. So berberine, as you know, is an antioxidant, is antibacterial, is antifungal. It's actually as good as Ozempic, stimulating GMP-1, by the way. So if anybody wants, Ozempic, just take 1 gram a day of berberine. You'll do better. So it blocks mast cells. And if you have a lot of GI problems and you suspect mast cells, butyrate also inhibits mast cells, but it acts primarily in the gut. Doesn't get absorbed very much. So if I have patients that don't do well at all with anything that we spoke about, I might add some berberine, I might add some butyrate. Especially, there's some people that just cannot tolerate flavonoids because they have phenol intolerance. Okay? So, the same way we measure diamine oxidase as an enzyme, we can measure the enzymes that break down phenols, one of which is catecholamine orthomethyltransferase, COMT, of course. So if they've got polymorphisms there, they cannot tolerate the flavonoids, so you've got to come up with something else. So in that case, berberine, butyrate would be possible choices.
It's so interesting that you brought up about the berberine, because when I interviewed Dr. Karen Herbst, she talked about berberine as she called it a baby GLP-1, and then we know now there's been studies looking at GLP-1s with mast cell activation, and I wanted to ask you about that, but in the interest of time, because I feel like people are already going to be overwhelmed, and you have such an incredible wealth of knowledge, so we may have to do another part of this conversation. I wish we had time to cover all of it.
I love our conversations.
Yeah. So it was just so great to chat with you again. And of course, so great to have Dr. Chopra here this time.
Thank you very much.
Thank you so much for sharing this incredible amount of information. I feel like, people are going to, I've already listened more than once, which I don't always do. And so I think a lot of people are going to probably have to listen a few times.
But seriously, and I think Linda, I had told you that before, I'd love us to work on a more sort of practical mini review or mini whatever about mast cell activation disorders, maybe for general family practice or something else that is likely to be seen by a lot of physicians and not necessarily the specialist.
Yeah, I think that would be great. Yeah,
like a review article.
Yeah, a mini review. Not a review to cover all the literature, which we can do. More like along the lines of what we were discussing. What are the confusing aspects? What are these questions? Why are, so maybe Dr. Chopra or Linda, you can make a little skeleton, the kind of questions that came up today, and that we can kind of put it together in the sense, okay, here's an introduction about the mast cell in general, with not too many references, just some very basic references. And then, why is it confusing? What does it mean if you have one and not the other? Is the treatment the same, or is it really, different? Et cetera, et cetera. It might not amount to anything eventually, but I think if we kick it around a few times, it will probably be decent.
I think we should do it.
Let's do it.
I like that idea.
Worst comes to worst, we'll put it on your website or whatever. Okay.
Yeah, I think we should shoot for something more than a because then we could do blog posts, about the article. So I think it's a great idea. I would love to do it, and I know we shared last time, and I want people to go back and check out that episode so they can find out more about Dr. Theoharides. And also, I will put in the show notes, all the relevant links so that you can have all that information. And I want to thank you so much for coming on the show again and sharing your knowledge with us. I really appreciate it.
By the way, if someone is desperate to see me, they can reach out basically to Nova Southeastern at the Institute of Neuroimmune Medicine. I do see patients once a month. That's it. Just 5, 6, however many they can fit in. And there are 2 wonderful nerve practitioners that help me out. But, I didn't used to do that, but there were so many requests that I slowly started saying, okay, type of thing. So, and as I said, if anybody's interested in some of the supplements I mentioned, either Amazon or Argonaut.com. They can find all of those.
Yeah, we'll have all that in the show notes so that they can easily find that. So, yeah,
and
wonderful.
And I didn't have anybody, Dr. Chopra, you're part of the woods anymore, seeing this patient. So I don't want to kind of start sending a lot of patients your way unless you tell me so. But I've got a lot from New England that they're desperate, especially because Dr. Mariana Castells at Brigham is leaving, if hasn't already left, and she shifted basically, from what I understand, her patients to some allergists who don't even believe that MCAD exists. So these patients are desperate now. Okay? I mean,
you have no idea. There's no one in New England who believes in MCAD.
I know.
Yeah.
Same thing with interstitial cystitis. Same thing with chronic fatigue syndrome. Same thing with fibromyalgia. It's like, I don't know why, but we're just so intransigent.
I'll be happy to help you
I'll
out.
let you know ahead of time. But there are some up there that I used to send to Mariana. But Mariana had shifted to seeing only mastocytosis patients, and then, as I'm hearing, she's leaving if she hasn't left already.
I think she has already left.
Yeah, she may have. It's a tremendous
She was going to do
vacuum
research
right now.
Yeah.
Yes, absolutely. Thank you so much. Well, there is so much to unpack from this conversation with Dr. Theoharides. I think I'm going to create some newsletters specific to this topic. So be sure to sign up for my Substack newsletter at hypermobilitymd.substack.com. Thank you so much for listening to this week's episode of the Bendy Bodies with the Hypermobility MD podcast. You can help us spread the word about joint hypermobility and related disorders by leaving a review and sharing the podcast. This helps raise awareness about these complex conditions. If you would like to dig deeper, you can meet with me one-on-one. Check out the available options on the services page of my website at hypermobilitymd.com. You can also find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, Twitter, or LinkedIn at hypermobilitymd. You can find Human Content, my producing team, at Human Content Pods on TikTok and Instagram. You can also find full video episodes up each week at Bendy Bodies Podcast on YouTube. To learn about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, and HIPAA release terms, or to reach out with any questions, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.